Good evening, everyone. Let me welcome all my viewers once again today on Heart Mitra channel. We connect with you on a daily basis and share information related to good cardiac health so that you are aware what to take care and how to take care of your heart. Along with sharing information on a daily basis, we also invite for you renowned cardiologists from the country who can talk to you as a friend and who can answer the questions which you have in your mind. So today I'm very glad that we have with us Dr. Babu Ezhumalai from the city of Chennai. Sir, welcome to the show.
Yeah,
I welcome
thank you,
you
sir.
here. Yeah.
Thank you for
So
inviting me for the
today,
show.
yeah, it's our indeed our pleasure to have you. Today we will be talking about an interesting topic related to cardiac health, and we keep on getting a lot of chats from and questions from our viewers from our follower group, and that is about whenever there is a cardiac event. So there are various procedures we hear about, which is like coronary angioplasty, which is also called stenting, and then bypass surgery. A lot of our viewers want to understand like what is the difference between the two. How does the doctors make a choice around that? So today we will talk about this topic. But before I start taking your questions, let me formally uh, introduce Dr. Babu to you. So Dr. Babu is a he has been all through and through done his medical studies right from his graduation time to his specialized training in cardiology from the very prestigious institute JIPMER in Puducherry, which is of national importance. He also has a fellowship in interventional cardiology from Fortis Escorts Hospital, Delhi. So he definitely has a Delhi connection as well for all of our viewers who are watching us live from the North Indian states. And he is also having a fellowship of American and European societies of cardiology. Now he has been an expert in coronary and structural heart interventions, and currently he is working as a senior interventional cardiologist and a heart failure specialist in Apollo hospitals at Chennai. Sir, let me with this introduction, invite you for your opening comments on this topic, and then we will take in the questions. So over to you.
Yeah, so good evening, everybody. So it's very nice to be in this live show in Facebook. So today we will be discussing about this. Which option to choose for a heart disease, whether it's a bypass surgery or angioplasty stenting. And I am Dr. Babu Ezhumalai, senior interventional cardiologist from Apollo Hospitals, Chennai. I'm also an heart failure specialist. So I do structural heart disease interventions like valve replacement, everything during catheter based. So I am an interventional cardiologist who basically does angioplasty. But we are the cardiologists only usually diagnose the disease and then like do echo or a coronary angiogram, and then we advise the patients whether to undergo angioplasty or bypass surgery. So that's how the role of cardiologist comes in deciding between angioplasty and bypass surgery. Yeah, so we can go into the show and then we'll discuss about further details during the show.
Great to have you, sir, and thanks for sparing out your time today for our viewers. Now, even before, I know that this is a little bit of a technical topic, maybe for viewers as well, and we'll try to, we'll request Dr. Babu to simplify it as much as possible. But even before we go into an angioplasty or a bypass surgery, let us try and understand from him that, in what situation a patient may go to a doctor or a cardiologist, for getting these done. Of course, in a heart attack kind of a situation. So if you can, sir, help us understand that what is actually heart attack and what are the critical symptoms which a patient may get, so that, he decides that he has to go and meet his cardiologist in an emergency.
Yeah, so heart attack is a very common term, which is many times used in movies, and those things are shown, and even a common layman person also knows about this. But there's a slight confusion about what is heart attack. So heart has three major blood vessels. So this is a blood supply to the heart is done by three major blood vessels, which we call it as coronary arteries. And these coronary arteries, as age advances, slowly the cholesterol deposition can happen within the lumen of the blood vessel. So, and gradual narrowing can happen. That leads to decrease in blood supply. That's what we call it as a coronary artery disease. But sometimes when this blockage happens, sudden 100% occlusion can happen. Like there is one side we have a gradual occlusion of the blood vessels, other side where a baseline blood vessel blockage is there. can be a 30% or 50 or 70% block. The remaining percentage, or so remaining part of the lumen gets suddenly occluded with the blood clotting, and that's where patient collapses as symptoms and all this in condition. We call it as a heart attack. So heart attack is a condition where there's a sudden 100% blood occlusion in any one of the blood vessel of the heart, that is in any one of the three major coronary arteries of the heart. So these patients will have severe chest pain. The most common symptom what they have is chest pain. So on that chest pain, what we call it as an angina. Angina means so blood vessel blockage leading to chest pain symptom, and this will be a severe rising pain. So patient will usually say they have a compressive type of chest pain. So no, they will have a chest pain where they'll have a kind of a tightness. They'll say as if a rope is tied across the chest, and then if it is pulled, there's more of squeezing, compressive type chest pain. And even it is described as such. If an elephant stands on the chest, that amount of discomfort they will have, and they have to definitely come to hospital. So that kind of situation will happen. The other sometimes this pain can radiate to the left arm also. So it can pain can get radiate to the left arm, and some people have a pain which is radiating to the jaw also. Jaw and the neck it can radiate, and very rarely it can go to the backside. All those things, but most common symptom is a squeezing type of compressive type of chest pain, and which is aggravated on movement. Whenever they exert, walk and move, because heart beats more that time, and then the demand is more, blood supply is less, and then they have a pain, and then can radiate to the left arm or to the neck or jaw. The other symptom what they commonly have is breathing difficulty, what we call it as a breathlessness or shortness of breath. So this breathing difficulty also will be maybe associated with along with chest pain in a heart attack patient. And then we may have profuse sweating. So the sweating is like such a way that the entire dress gets drenched, that they can have that symptom. Then sometimes they have this GA symptom, like they can have a nausea, vomiting, and then so that may be there. And few people may have a giddiness, light attendance also they may face. And so these are the symptoms related to heart attack. So heart disease as such can have other symptoms, but heart attack usually will have a chest pain, breathing difficulty, and then they may have a giddiness and the nausea, vomiting, and profuse sweating. That is what is very important in heart attack symptoms. But
Thank
the
you,
same
Dr.
patient,
Babu, for
yeah. So the same patient may come. This is what the heart attack in emergency situation. So they reach the hospital, but same patient may have a blood vessel blockage, as I said, gradually, when they come to the OPD. It's not like always a patient with blood vessel block has to come to in the heart, has to come to the emergency. So those patients mostly will have the chest pain symptom when they walk. That's what we ask. When you are walking or climbing steps, if you are feeling the symptom, it's more related to heart disease, because pain in the chest can be because of various things, a gastric problem or other things. Whereas cardiac disease will have a chest pain where they are walking or exerting, that is moving around, they will have symptoms of chest pain, and this symptom will be relieved on taking rest. That's what we call it as angina. That is very important. So with this symptom only, most of the patients come to the hospital. Very rarely pain may not be there, because a diabetic patient may not have pain, because we know that in diabetes, the nerve sensation will be affected. They have a lower limb ulcer or pain, they may not feel that pain. So similarly, this pain symptom arising from the chest, so that also may be masked, and they may not have this chest pain, and they may come with some altered symptoms, like they may come with a breathing difficulty or giddiness, and all those symptoms can happen. So that time also, this we call it as an angina equivalent. These symptoms may be considered something equivalent to angina or chest pain. Then we evaluate those patients also. These I'm telling that patients who come to OPD, so blood vessel blockage, which is not like 100% or sudden, but gradually occurring, still it is critical blockage. So then also they reach to hospital, and then we take them also for angiography.
all right. So I think Dr. Babu has shared in a very, very elaborate way that what can be, various symptoms which one should be looking out for a heart attack. And very importantly, he has emphasized that there would be, some major symptoms like very, very way like something like an elephant standing on the heart, that level of chest pain. And then there are some indicative symptoms which he has also shared, like sweating or even pain in the jaw or in the arm. So there would be major and minor symptoms. And I think it will be important if our viewers, even if you have the minor symptoms, please don't ignore it, because we generally have a sense of ignorance as well on many times. Please go and talk to your cardiologist. Earlier you reach, better it would be, for you, and he would be able to help you as well. So now, once a patient has gone through these symptoms, identified and reached to a cardiologist, now we know that there are various ways of managing a patient. There are medically through some medicines it will be done, and or there would be some interventions or surgeries are also available, and we'll come on to that. But as a doctor, sir, what are the few investigations which you do? We all have heard about things like ECG or angiography. So, like, are these the basic things which you do, or you do more? And what do you try to find out in an ECG or an
Yeah.
angiography
So,
in the patient?
yeah. So when a patient comes to emergency with heart attack, we have a set protocol. Like anybody who reaches in hospital within 10 minutes, as per the guidelines, you have to do with a chest pain symptom, symptom of heart attack. And we have a doubt that ECG, what we call it, the electrocardiograph, has to be taken within 10 minutes of arriving hospital. Okay, so we have to do that and we have to diagnose. With the ECG, we will be able to diagnose heart attack in majority of cases. So once that is done, then we also ask for a echocardiography. Echocardiography is nothing but ultrasound of the heart. Ultrasound is like no sonogram. Everybody knows about ultrasound of the abdomen, where they see anatomy and all of the abdomen. So similarly, ultrasonography of the heart is called echocardiogram, where we look for the heart function, valves, and all those things. We look for that. So these two tests. In addition, when patient comes to emergency, the third test, what is commonly done is a blood test, where we look for troponin. Troponin is the blood cardiac biomarker. So that is a blood test which is done, and it's very shortly available. So in emergency, within 15 to 20 minutes, we get that report. That also gets elevated even when there is a mild heart attack. Also, it gets elevated. So sometimes ECG maybe rarely it may be normal or very minor changes may be there, especially when heart attack happens in the posterior surface of the heart. So we have heart as an anterior surface, and then we have an inferior or posterior surface, because ECG is placed in the anterior and the front part of the chest. Sometimes we may not see those changes when posterior part of heart is affected. That time we have to go for the echocardiography. That also may not show, very rarely changes. Then we go for the blood test. It's called cardiac troponin level. That gets elevated very early. Nowadays have a high sensitivity troponin level. Even within 2 to 3 hours of having a heart attack, this gets elevated. Previous test we have to wait for 6 hours, but nowadays we have a blood test. It's called high sensitivity troponin, which can get elevated very early, and then we'll be able to do that. And if it is elevated initially only slightly, then we look for serial ECG also. So one ECG we take, and then if you have a doubt, even if it is normal, we don't send the patient. We advise them to be on observation. We repeat a ECG after some time. We repeat this blood test also after some time, so that we'll be able to changes which are happening progressively. But when a patient comes to the OPD, so these are the basic tests with which we diagnose a heart attack. And so I'm telling you, the same patient may come to the OPD also, where he doesn't have a heart attack condition, but still he has a blood vessel blockage in the heart vessel, blood vessel. So, where we call it as a coronary artery disease. So those patients do ECG and echo, most common basic test for the heart. And when we have a doubt, when it's not very clear, then we sometimes we ask for a treadmill test also. Treadmill is excess ECG, in short, what we have to say. So we ask them to walk on the treadmill, and also we do the simultaneous ECG and serial ECGs, and then we ask them to, as they walk, the speed increases and the inclination of the treadmill increases. There's a standard set protocol, so that we'll be able to compare for this age how much they are walking, and then what are the changes happen. So in OPD, when they come, so outpatient department, as an elective patient, sometimes we do ECG, echo, and we have a doubt. If it's not very clear with what we have, the ECG and echo, we go for a treadmill test also to see that. But in emergency, usually we don't advise for a treadmill test. So these are the tests we've done. And there is something called CT coronary angiography. So treadmill test basically is a screening test. So ECG and echo also. ECG and echo doesn't show that it is totally, if it is something abnormal, we take it as abnormal. Suppose if it is normal, we cannot rule out that it is there's no disease, because when patients having an ongoing symptom and critically what we call it as a ischemia, where blood flow is reduced, that time resting ECG may show changes. And sometimes these changes may not be there, because patient comes as symptoms and then they'll come after some time. That time ECG, resting ECG may not show. I'm telling in an OPD basis. That time we go for echo. Echo also may not show, because echo changes in echo, heart dysfunction will happen when blood vessel flow is critically reduced. So and the heart function starts reducing. That time we'll be able to see changes in echo. But then we go for a treadmill test. Treadmill test is a screening test. Just like for COVID, we have a RT-PCR test. This is a screening test. So screening test means these tests sometimes may have false positive also. That is, patient may not have disease, still then some changes may happen. So 70% of no, it's only treadmill is only reliable 70% of the times. What we say is reliability is only 70%. That means out of 100 patients who get a positive in treadmill, positive means abnormal, abnormality seen in the treadmill. If you do go for angiography, only 70% may have disease. Remaining 30% may not have a disease, or they will have only mild disease or something. So then comes the next level is the CT coronary angiography, where it's nothing but a CT scan, and then we look for heart blood vessel disease also. So an contrast will be injected. So whenever blood vessel has to be seen in the body, contrast will be injected anywhere from head to foot, whether it's a brain vessel, a heart vessel, or low limb vessel. So only contrast has to be injected. Only then we'll be able to differentiate or delineate this blood vessel from the neighboring tissues. Just like when we draw a diagram in school pictures, and so we put red color or blue color for all these blood vessels. So something similar to, because so that we see it from neighboring tissues to differentiate that. So similarly, to see a blood vessel, we have to fill it with a contrast. Only then it can be seen. So that is called angiography. And doing looking at the heart blood vessel is called coronary angiography. And if it is done through CT, it is called CT coronary angiography. Depending on the slice of CT, like initially it was 16 slice, then we have 64 slice, so with 128, and nowadays we have even 640 slice CTs at some places, and that gives higher resolution of heart blood vessel images. Then we'll be able to make out. Again, the reliability of CT coronary angiography roughly maybe 90 or 95%, and the final gold standard test is always coronary angiogram. So whether the patient comes in emergency, where ECG, echo, or blood test cardiac troponin is abnormal, or when they come to the OPD, where we do ECG echo, we find abnormal, we directly go for coronary angiography, or we do a TMT, then we go for coronary angiography. Some patients, they do themselves, or they do a CT coronary angiography, and then they come. Any abnormality in any of these tests, the final gold standard test or confirmatory test where we rely 100%. The 100% reliable test is coronary angiography done by a cardiologist in cath lab. That is called conventional angiography. So this is the final test for heart to detect any blood vessel blockage, whether a patient comes in OPD or in emergency, called coronary angiography, which is the final test.
Okay. Okay, so I think that's quite elaborate process, which you can hear it from an expert cardiologist who is day in and day out managing hundreds of patients. For our viewers, some of the things may just be very technical in this. Just simplifying, I think if you visit your cardiologist with the chest pain symptoms, there would be, 3 or 4 investigations which will be done. Don't deny them, because it is extremely important that they see through your body, that what is going on, so that they can offer you perfect help. So ECG, 2D echo, and I think CT angio, as you mentioned. So these will be important to understand. And then to understand what's going inside your body, they'll also, they'll do an angiography. By a cardiologist will be doing that in a cath lab to understand that how much is the blockages in the arteries, and what to go and do forward. Thank you very much, sir, explaining this. I just try to simplify it for some of the viewers who
Yeah,
may
yeah,
not be
yeah,
very,
yeah.
very technical.
So, yeah,
Uh,
uh, if I have to
w-
just
yeah,
tell two more lines about this angiography, so that this
yeah.
our general public also will understand. So, coronary angiography, as I said, is the final test to see whether any blood vessel blockage is there in heart. So, how we do is we just put one needle in the hand. So it will be a small needle in the wrist. What we put, it will be like a starting drips, saline drips. What we say commonly, starting a normal saline. That kind of small needle injection only. We put usually in the wrist or in the groin blood vessel. Previously, we were doing from the groin blood vessel. Nowadays, we do in the hand, wrist. And then the procedure takes 15 to 20 minutes, where a small catheter, it's called a tube, which is passed from the hand wrist under the fluoroscopy, like X-ray imaging, what we do in cath lab. And then the catheter is taken to the heart. So we selectively inject contrast into the blood vessels. So no heart blood vessels. So let we see how much block is there, what are the pressure changes. So that gives maximum information. That's how we diagnose whether patient really has a heart blood vessel block and what to be done, because whether he has to undergo angioplasty, whether he has to undergo bypass surgery, whether he has to be on medicine, everything is decided on this one single test, and which is the final gold standard test.
All right. So thank you for helping us understand this very, very important information in last 2 minutes you have shared. Sir, please help us also understand now. You mentioned about, after this blockages you see through coronary angiography, you make a decision that whether a surgery has to be done or an angioplasty has to be done, or let's say medical intervention. Can you help us understand the difference between these three things for our
Yeah.
better understanding of patients?
Yeah. So, what I commonly tell my patients and the relatives of the patient also, the idea of taking a patient for angiography is to diagnose whether they have a heart disease, blood vessel blockage. If blood vessel blockage is there, we have only three outcomes after doing angio. Either they go on a medical treatment if mild or medium blockage is there. If some critical blockage is there, they go for a angioplasty or bypass surgery. So, any blockage more than 70% occlusion in the blood vessel, okay, is considered as a critical blockage, which has to be managed either by angioplasty or bypass surgery. Any blockage less than 70% can be kept on medical treatment and then followed. Sometimes when we have a doubt between borderline lesions, where the 50 to 70%, when we have a doubt, we have further investigations, further tests to identify whether they are really critical. But functionally, any blockage more than 70% is considered critical. That means it is going to reduce the blood flow in the blood vessel. So heart blood vessel is a lumen, it's like a tube. So that if that tube is blocked more than 70%, the lumen of the tube is blocked, blood vessel is blocked more than 70%, blood flow is going to be reduced to the heart. So in that case, we have to relieve that blockage with an angioplasty or bypass surgery. Medical treatment will be continued for all patients, irrespective of the severity of the blockage, because it's not whether it's a mild, medium, or severe blockage. So medical treatment will be continued. But in addition, angioplasty or bypass surgery is done for any blockage more than 70%. And the heart attack patient will definitely have a close to 100% or 19% blockage when they come to hospital when we do angio. That has to be immediately relieved, where we do call it as an emergency angioplasty, where we remove that blockage, open that blockage with an angioplasty. So
Basically,
I
what
can
you're saying
answer,
is
yeah,
that if the blockage is less than 70%, and that you will find through the angiography which you initially mentioned,
yeah,
if the blockage is less than 70%, then you will not open up the patient or not insert anything into it. You will medically manage it with the medicines only, and patient doesn't need to undergo any procedure, right?
yeah,
And
yeah,
now,
yeah,
if it is more than 70%, so then you have to decide whether an angioplasty would be done or a bypass surgery has to be done. Can you help our viewers understand, sir, the difference between the two? Because for a common man, it's like both the things are like if you're inserting something, is getting admitted some procedure,
yeah.
so it's a surgery or a procedure. So please help us understand the difference.
Yeah. So bypass surgery is something which has been there for a long time. So more than we say that close to 50 years or something we are doing, or even more than beyond that. So where an angioplasty came somewhere in the 90s or something, it started. Uh, Bypass surgery, what we call it as an open heart surgery. Conventionally, where the chest wall, the chest sternal bone will be mid sternal bone will be open, and patient has to be on general anesthesia. So because he'll be unconscious, he'll be on ventilator, and then the surgeon will open the chest wall, and then this surgery is performed where any blood vessel blockage. So it's like a bypass. When a road is blocked, we go put another bypass road like that. When a blood vessel blocked, another blood vessel is taken from either from the lower limb. Nowadays they do take it from the even from the hand, the forearm they take it, or sometimes it is taken from the chest wall also, and then the connection is given. So when blood vessel blockage is there, another we give a connection, another beyond that, like this. So that's how bypass surgery is done, and
So you
patient
don't
has to
try to
be
open the blocked vessel, but you just bypass it. A
bypass and
surgeon
then
will surgeon
connected.
will do it. And okay.
Connected. Whereas in an angioplasty, wherever the blockage is there, so it's something similar to undergoing an angiography, what I said earlier. So we put a needle, it's just a minimally invasive procedure. There is no cutting, no stitching, no nothing is there, whereas in angioplasty. So we put a needle and then usually in the hand or wrist or in the groin blood vessel. And then under fluoroscopy, we pass a catheter, just like an angiography. We take the catheter close to the heart, and wherever that blockage is there, we pass wire across inside that blood vessel, and then across that blockage, we try to, if it is a soft clot which is formed in a heart attack, we try to aspirate and then remove that. When we suck and then remove that, using that, we have a suction catheter. Otherwise, if it is a well-formed clot, we just go do some balloon dilatation. We create passage because it is occluded. We cross a blood vessel balloon, and then we do balloon dilatation. And so that some passage is created. Then we take a stent. Stent is fine metal, thin metal, so which is drug coated stent, what we usually take across that blood vessel blockage. and then we what we call commonly people call it as something, layman says it as like a spring which goes and then expands. So we mechanically we dilate it so that it will not get cramped again. So that will, so that it acts as a skeleton, and then blood vessel and then flow is increased across the blood vessel. So angioplasty is like going across the blood vessel, opening the blockage. And as you correctly said, sir, bypass surgery is like we don't open the blood vessel, but we just go and then bypass that and give a connection.
Okay.
That's it.
And for doing angioplasty, you don't also need to cut open the chest or the bones.
Yeah,
You
no,
just simply insert, a needle, a catheter, and you will open the vessel, right?
yeah, open the vessel, and then there is no only we don't do anything. It's just we go from the, as I said, no, blood vessel from the hand or from the groin blood vessel. We approach that. See, I can further elaborate on this because this is the basic idea. And even bypass surgery, many improvements have come because science has developed now, because that was the traditionally that was done like that. So now let me first elaborate on angioplasty. So what we call it as PCA or PTCA, what we say. So angioplasty and stenting is something similar. Once we go into the blood vessel and then we open it, the balloon dilatation is called angioplasty. And once we put that spring like metal inside that, it's called stenting. This procedure can be done in emergency also. Like when somebody comes with a heart attack, that time we don't advise a patient to go for a bypass surgery. In emergency, once heart attack patient comes reaches hospital, in addition to doing this basic test like ECG, echo, and troponin, we also load them. We also give them blood thinners. Like 2 blood thinners will be given. That is called loading antiplatelets. So once that is given, so we take the patient for emergency angio, immediate angiography. And once we see the angiography as a blood vessel blockage is there, we tell the patients and attendants, and then we go and proceed and then do this emergency angioplasty stenting also. We confirm with angiography, that is a test. And once blockage is seen, then we go and then open that, we proceed further and open the blood vessel and then do angioplasty. But and then patient will be in ICU for maybe 1 day or something, usual thing, and a couple of days in ward, and then he'll get discharged. And in maybe stay will be 3 days or something. And once he goes home, and then if it's an elective angioplasty, means somebody comes to the OPD and then gets an angioplasty, angioplasty. So by 1 week or 10 days, he'll be able to return to his normal routine. Whereas a patient who underwent an emergency angioplasty, where he came with a heart attack, so we usually keep him in hospital for 5 days, depending on the recovery. Some people may recover earlier also, we discharge them. And then they go home and then rest at home for a couple of weeks, and then they come back, and then that's how in a month or something, they'll be able to return back to their normal life. Whereas
Got it.
in open heart surgery, once this blood thinners are usually stopped, there are some exceptions, but once they give a blood thinner, they have to withhold this blood thinner for 5 days or something, 3 to 5 days, because they're going to cut open the chest and it may lead to bleeding. Bleeding means that more blood transfusion has to be given. There are exceptions where in emergency, even bleeding is there, they go and then take that. But generally, blood thinners are withheld. So in emergency angioplasty, where we give antiplatelets or blood thinner medications in emergency room only, then these patients may not be able to go for a surgery because they have to hold it. That's why in emergency heart attack, we always go for an angioplasty. But when a patient comes to as an elective patient or after stabilization of this emergency condition, then patient after doing an angiography, when we see patient has multi-vessel blockage, triple vessel disease, all 3 vessels are blocked, or multiple blocks in even in a single vessel, then we call something as a left main, because right side vessel comes as a single vessel, it's a C-shaped. It's called right coronary artery, and left side blood vessel comes as a single. It originates as a single vessel. It's called left main, and then it's like Y-shaped. It comes like this, and then divides into left front and back vessel. So the left main vessel is so important because that is going to give major 2/3 of the blood supply to the heart. And as I said previously, for other coronary arteries, if they have 70% blockage, we consider it critical. Whereas in left main vessel, even a 50% blockage is considered critical. So when they have a left main disease, blockage the left main vessel, and when they have blockage in multiple vessels, all 3 vessels are blocked. When they have so those conditions, some we advise patients to go for a bypass surgery. But there are exceptions for this also. But generally, this is a dictum. When they have blockage in this kind of thing, or when multiple stents have to be put, usually we advise patients to go for bypass surgery, or we give that option also. So bypass surgery. So before going for bypass surgery, patient has to undergo a pre-op evaluation whether he's fit for bypass surgery. So and then we do from not only from ECG echo, we do for a chest X-ray. Sometimes some people will ask for ultrasound abdomen because they have a kidney disease. We look for all parameters starting from hemoglobin, what is the WBC count, blood test we do. And then we see what is the lung condition. Sometimes we ask for a pulmonary function test to know what is the lung condition status. So all these tests, and what is the blood group, especially because there will be blood loss during bypass surgery procedure, where which is very minimal during angioplasty, but definitely blood loss is going to happen during bypass surgery. So we need to have a specific blood pack units grouped, specific cross match ready for that person. So all these things are involved in bypass surgery, and patient will be undergoing in a general anesthesia, whereas in angioplasty we can do it in the local anesthesia most of the times. Now, where patient will be conscious and will be talking to the patient. But a general anesthesia means they'll be on a ventilator in bypass surgery. So at least, and then post surgery also they'll be on ventilator for at least 1 day or something like that, 1 or 2 days, depending on the recovery. After that, they'll be in ICU, and then patient will have some lot of drain tubes which is coming out of heart from the side and front, because they, to avoid any blood collection in a bypass surgery. They will have stitches in the lower limb or in the hand where the graft is taken. So suppose nowadays people do arterial grafting also, where this graft is taken only from the chest, but conventionally it is taken from the lower limb, 1 or 2 lower limb, and then sometimes the forearm also it is taken. So they will have extra stitches or this thing dressing in those places, and then they'll be in ward in ICU for a couple of days. Then they'll go to the ward for 5 days or something. So totally they'll be in hospital for 6 or 7 days after undergoing bypass surgery, and then they get discharged. When we discharge them, we ask them to move around and see that they're able to move, though with support. They go home, then they'll come for a review in the first couple of weeks, and then where they remove the stitches, and then it will take at least 6 to 12 weeks for them to completely recover, where they'll be able to go for a job, resume the job, or go for other activities. It will take at least 6 to 12 weeks depending on their recovery, because the sternal bone, which is mid-sternal bone, which is cut open, has to heal. So that bone union or reunion to happen, it may take even 2 months. That is 6 to 12 weeks approximately takes. And but
So
nowadays
as
it's
you
it's a bypass
so
surgery also slightly improvised, because I should justify telling that also. So previously we were doing open heart surgery where they were using cutting open in the central of the chest. Now we have something called MICS, minimally invasive cardiac surgery. So where they, instead of opening in the central chest, they do a small incision the side. They give a small incision the side like this, and then that reduces the number of stays of hospital. Blood loss is less. Patient recovery is faster. That is called MICS, mixed or minimally invasive cardiac surgery. Not only for bypass surgery, even some valve replacement can be done with that. So there is a lot of changes, improvements have come in angioplasty, and then in this bypass surgery also. So usually in general, we say for angioplasty, anytime we can take, only we look for a kidney function test and hemoglobin, basic things, and then we go and then do the procedure. At any time we can see, we can just talk to a patient. If it is okay, then we need a few 3 4 hours fasting. We can take a patient for angioplasty. In emergency, we don't bother about that. Also, we take the patient for angioplasty. But in bypass surgery, many times it is a planned procedure where we have to initially evaluate the patient whether he's fit for the procedure. If he undergoes bypass surgery, what all the complications, everything we have to look, and then from blood, few things has to be reserved for the patient. And then after surgery, will be angioplasty patient will be there in hospital for 3 days maximum, 1 day in ICU, 2 days ward. A bypass surgery patient who has undergone a bypass surgery will be in ICU for a couple of days, in ward for 5 days to 26 to 7 days. And recovery is earlier for an angioplasty patient, because by I think 1 week to 10 days he'll be back to normal. Whereas an bypass surgery patient will take 6 to 12 weeks to recover. Complete recovery will take like that. And there are
all
some
right.
chances of infection, which is almost negligible with an angioplasty. But bypass surgery patient, because they have an, in like any other surgery, they have an incision and scar and all those things, they may have some infection, chances of infection are there, and recovery, because, and so that may take slightly longer time. That's all.
Okay. So I think Dr. Babu has covered this whole piece, and explained the differences to us in a very elaborate way. Just summarizing a few of them. So as we hear you, sir, so and correct me if our understanding is wrong on this, that doing an angioplasty is relatively easier for the patient and for the hospital staff as well, as compared to a cardiac surgery. The hospital stay may be lesser, maybe less than a week, 4 to 5 days for an angioplasty, and maybe little longer, anything between 1 to 2 weeks for a surgery. And even the recovery period would be maybe 2 to 3 weeks fully back to work if angioplasty is done, and maybe 12 to 18 weeks if cardiac surgery is done. So
Yeah.
from all this perspective, it seems like, that's a little more complex procedure to do a cardiac surgery as compared to an angioplasty. But also, sir, in the same breath, we'd like to, know from you that how do you decide medically that which patient will require angioplasty and which patient will definitely require a cardiac surgery, and also, help us understand that whether it is a medical decision to be taken by the doctors based on the patient situation, or patient has a say in this, like, patient has to decide what to do. Please help us understand these two things.
Yeah. So, see, first we have to look for the anatomy. So we'll go by this thing. What are the blood vessel anatomy, and what is the patient's clinical status? And most of the time, these two parameters only will help us in deciding what he has to undergo. So, as I said, in an emergency, when patient has heart attack, when he comes to emergency, when we do an emergency angiography, immediately we do emergency angioplasty. That time, mostly we don't advise bypass surgery for the patient. So that is one indication where we are very clear that it has to be done. And this angioplasty also has to be done. As I said, ECG has to be taken within 10 minutes of hospital arrival, and the angioplasty bypass, angioplasty, emergency angioplasty has to be done within 90 minutes as per the recommendation of a patient. Once the patient reaches hospital, within 90 minutes, we have to do a emergency angioplasty. At least we have to open the blood vessel. So that's how it's a usual recommendation. And when a patient has a single block, or one or two blocks in one or two blood vessels, then we advise them angioplasty. And previously, if a patient has a calcification, because long-standing blood vessel block can get calcified. Initially, it will be a soft, then it becomes firm, and after days goes on, it may become calcified. The blood vessel blockage will become hard like a wall. So if that thing was there, and then previously, maybe years or many years or decades before, people were advising patients to go for a bypass surgery. But nowadays, we have so many advancements in angioplasty also, where even if calcification is there, what we call the calcified or hard lesions, hard blood vessel blockage, then we can do something called a rotablation, where we do a pass a wire and then do drilling inside the coronary artery. And then we have conditions where we use just like kidney stones or broken with ultrasound, something like that. We have ultrasonic waves where we can pass inside the heart with a wire. We pass a blood vessel. It's called intravascular lithotripsy, where we see inside the vessel we pass a balloon, and then we try to create some cracks in these calcified hard lesions. Then we can go do angioplasty. So previously, these patients were sent blindly for a bypass surgery. Nowadays, that we have taken over. I mean, cardiologists have taken over and then doing angioplasty for that. And when total occlusion, 100% blockage, when it's long standing, so it's a chronic total occlusion, what we say. So sudden 100% occlusion is the blockage is going to be soft, and then heart attack, and we do angioplasty. When this blockage is there for long standing, for more than 3 months, which is called a chronic or long-standing blockage. So that blockage, sometimes opening and success rate of this blockage may be slightly less. It may not be 100% always, sometimes, because sometimes there may be a failure in angioplasty. Those patients also, initially they were referring for bypass surgery, but nowadays we have improvement in techniques where we open the blood vessel directly in, we say, in the front of the blood vessel. Sometimes we go from the alternate, opposite blood vessel, come in the reverse direction also, we open, that's called retrograde angioplasty. So those improvements have come. And multi-vessel blockage, or patients has a main vessel and a branch vessel. So it will be like Y-shaped. So main vessel blockage will be there, and this thing Y-shaped blockages. So it's called bifurcation lesions, where we were sending them for surgery. Nowadays we do angioplasty, and that is happening for the last maybe 2 decades or something. We are doing this. So those patients which were initially who were going for bypass surgery, complex lesions, what we say, complex blockages. Nowadays we are doing angioplasty, and if I have to say, other thing is that multivessel disease. So nowadays, if it is going to have a multiple blockage, where we have to put 5, 6, 7 stents are there. In that case, we advise the patients better to undergo an angioplasty. And again, if what we call it as a triple vessel disease, see, whenever the triple vessel, all three vessels are diseased and with multiple blocks, it's not a short blockage, long blocks are there. And then in that case, we give an option for bypass surgery. We discuss with the patients. And as I said, left main vessel. So left main vessel, if it is again, there are some places in the left main only where we see whether it's the beginning of the vessel or where it's the region where it's like in Y. So whether it's the beginning of the vessel or the Y-shaped region where the bifurcation, what we say, again, depending on that, it may change. But in general, nowadays, when multiple blocks are there, when triple vessel, all three vessels are blocked, if involvement of left main vessel also is there, where we consider patients for bypass surgery option also we give. Otherwise, most of the time, angioplasty can be done. We advise the patient, but when sometimes the kidney function is altered too much, creatinine is high, then sometimes we advise the patient because for angioplasty and angiography, we are going to use contrast. So when you're using contrast, kidney function should be fine. Otherwise, kidney function can get altered during the procedure, and sometimes they may land up in dialysis. For those patients, we advise them to go for angioplasty. I mean, bypass surgery, we give an option. And then before going for bypass surgery, we also not only see this anatomy, the same patient, again, the situation may vary. Suppose we see a patient at 85 years, 90 years, they may develop a heart attack. That time, we will not advise them for bypass surgery. We go for angioplasty. As I said, in clinical patient's parameters. In emergency condition, angioplasty. The patient is very elderly or very fragile, very low body weight, and then those patients who has multiple comorbidities, like they have a lung disease, they have a kidney disease, or they have a liver disease, so many things, especially when they have lung disease, which is very common in people who smoke, people who are elderly. So those patients, they have a lung disease also, because in bypass surgery, they have to be on a ventilator, so which is not essential for angioplasty. So those patients are advised to undergo angioplasty. So suppose a 50 years patient comes with multivessel blockage, all three vessels are blocked, and he has a triple vessel disease, involvement of left main blood vessel also. We may advise them for bypass surgery. We give them an option of bypass surgery also. So, and the same patient, suppose he's at 85 years or 90 years, or he's 75 years also. So suppose he has a multivessel blockage, and if he's having a lung disease, multiple comorbidities, so in that case, then we advise them for angioplasty. So that depending on the clinical condition, it may change. Similarly, if a patient has a one blood vessel blockage or two blood vessel blockage also, if he's having an associated abnormality, like there's maybe a valve leak, he may have a valve regurgitation. So in any one of the heart valves or the valve stenosis, some valve problem, where he has to undergo open surgery for the valve, then we advise them to undergo bypass surgery along with that, because both can be treated in a single condition. Again, those conditions, those switching also have been changing now, because nowadays we do valve replacement also, like no catheter based thing. But in general, anybody has a multivessel disease, multiple blockage, triple vessel disease, and if they have a left main disease, we give them an option for bypass surgery. And if they have to undergo multiple procedures in the heart, then they may go for a bypass surgery. We advise them, we give them an option. Otherwise, most of the procedures nowadays we can do angioplasty. And then we have nowadays newer stents where the life of the stents are longer, and then we have more research data coming where patients who undergone angioplasty also they survive for longer time where the blockage is less,
Got
and
it.
then they do well.
So,
Yeah,
so I think that's a again a very elaborate thing you have explained. I hope our viewers are able to understand this in a simplified language. Uh, I think if you have to really understand this whole thing, if your question was that when a patient is recommended for a surgery and when an angioplasty is done, you can simply rewind this program as well. This is going to stay here and listen to Dr. Babu once again as well, to pick up this knowledge and trust your doctors. If you're a cardiologist, this is a medical technical decision. As a patient, you may not be aware about anatomy of the heart or clinical situation. Of course, your doctor will keep you informed, but then I think here it's important that you trust your cardiologist that what is he sharing with you. So
yeah.
just one
So
final question on this. Out of 100 patients, which you get who have more than 70% blockage, how many of them, may require a cardiac bypass surgery, and how many you can manage with the angioplasty?
see, again, as I said, multiple factors is to be considered before embarking
Just
on
a general
angioplasty or bypass
percentage.
surgery.
Yeah.
But general nowadays, we will say that there are many patients, maybe out of 100 patients, maybe 70% will undergo angioplasty.
Okay,
So,
so I
and
think a
bypass surgery less is less, because we have techniques improved in angioplasty also.
so a vast
Uh,
majority of patients can be managed with an easier procedure, which is cardiac angioplasty. And still maybe 25-30% patients, as said by Dr. Babu, they may require a bypass surgery, so which is there, and
yeah.
and take
Maybe
this decision along with your
if you
doctor.
ask a cardiac surgeon, so because he'll be seeing more of I'm a cardiologist, he'll be seeing more of open heart surgery patients or bypass surgery patients. So the number may be slightly different what they say. But only giving the percentage of blood vessel blockage and then answering because somebody sees this and tomorrow they should not misunderstand that. So we are not telling about clinical parameters and other conditions we are not discussing. Only about this, the number of blockage is 70% and the number of patients who undergo procedures will be angioplasty will be more common.
Yeah, but I think whatever it's important to understand as a viewer or as a patient that there are multiple medical interventions which are available today to save you. Whether it is, a doctor will try to do a medical management, or through an angioplasty they will find out, through angiography they will find out whether you can be managed with a plasty or you need to undergo surgery. But I think across the patient condition there are solutions which are available. What you have to do is don't overlook the symptoms which you may have. If you have symptoms of heart attack, go to your doctor early and trust your doctor. I think let him, allow him to do the required investigations, and take a decision along with him that what's best for your health, and to recover out of this. And the recovery rates
Okay.
will of course be very, very good whichever procedure you choose to go for. Well, I think Dr. Babu, you have been very kind, I think, in helping us understand this complex subject, and you try to simplify and elaborate this as much as possible. But even before I, conclude this program and thank all my viewers who may have watched us live or who may watch us later on as well, if there is anything, still you want to highlight here, emphasize, or quickly summarize, I give it back to you.
Yeah, so blood vessel blockage in heart is called so there can be a presentation which can patient can come to emergency. We call it as a heart attack, or they come to the OPD. We do basic tests and then we do take the patient for angiography, coronary angiography. And depending on the blockage, severity of the blockage, if more than 70% in any of the major blood vessels, we advise them to undergo an angioplasty or bypass surgery. And we doctors, cardiologists are there to help you because angiography is done by cardiologists and cardiologists or cardiac surgeons are there to help the patients. So, as you asked in one of the last questions, if some blockages, even for my patients, I advise only angioplasty. We will not talk about bypass surgery. Few blockages, we advise them, even if they request for angioplasty, we tell them bypass surgery is fine. We try to convince them. There are some areas where a patient is given both options. So there, with the help of a cardiologist, with the help of a doctor, with the help of a cardiac surgeon, then you will be able to, the patient and the relatives will be able to take a better decision. So we some conditions we have to provide both the options as per literature, as per the guidelines recommendation. So we are there to help the patients, and they can clarify their doubts as many times possible, and then they can choose whatever is best possible for the patient. If there's only one option available, definitely we are going to give one option for conditions where either angioplasty or bypass surgery. Few conditions may need both the options to be given for the patient, and in those situations, we'll help the patient to take the right decision.
All right. So on this note, let me thank Dr. Babu as well for sparing out his time and sharing with all of us his knowledge on this subject, and helping us to really understand this subject and make us wiser. If all our viewers, if you have anyone in your family or friend circle who may be undergoing a cardiac disease, or who may have encountered such a situation, you can simply share the link of this program with them, and this conversation can be very useful for them to understand how your doctor is going to take a decision and what is your role in this whole piece. I think the way Dr. Babu has explained the whole subject to us, this discussion can be very useful for general practitioners as well, so that they can also guide their patients while they refer and recommend them to go to a cardiology center. So on this note, thank you so very much, and we'll take your leave. Dr. Babu, thank you so very much. The viewers
Thank you.
can visit him in case you want more information. Go to your nearest cardiologist. If you are in Tamil Nadu, Chennai, you can visit Dr. Babu in Apollo hospitals in Chennai, uh, or drop a message to him here in the chat. Thank you so very much, and good night, everyone. Good night. Thank you, Dr. Babu.
Thank you. Thank you.